From Pakistan in 2008, and she has done her MRCP from UK, MRCP Respiratory Medicine, and she is lead in asthma and pleural diseases in the trust. Madam, please come on the stage for your
I am going to discuss basically severe asthma investigation. I'll touch on the outline of my presentation will be widely discussing asthma today and changes to the GINA 2023 guidelines. I'm going to stress the importance of what is difficult asthma and what is severe asthma, the pathophysiology of severe asthma, assessment, outline of investigations, and multidisciplinary approach to severe asthma management options, and so on. So asthma is one of the most common chronic non-communicable diseases worldwide. It affects more than 300 million people, and the mortality of asthma, however, has reduced in the recent past. Still, it is a cause of high morbidity in large number of affected population. It accounts for 2 to 3% of primary care consultations, 60,000 hospital admissions, and 200,000 bed days per year in the UK. It's important to discuss. 4% of patients have severe asthma by definition. So this is the latest GINA guidance, and you can see they focus on assess, adjust, review, asthma management, confirmation of diagnosis, treatment of modifiable risk factors, comorbid conditions, and we need to tackle symptoms, exacerbations, and declining lung function. So the first step, I know this has come since 2020, but in the 2023 guidance they added track 1, which is the LAVA ICS combination in step 1, what we call as a Martrigine. And in track 2 we have SABA along with ICS whenever SABA is taken. So there's no role of short-acting beta agonist alone in management of any sort of asthma. Sometimes we start here in step 4 or step 5, and then if the patient improves, we go down to the most appropriate step and can go down to step 1. But just as you know, now step 1 does not include SABA alone, so we need to stress the importance of that whenever we discuss management of asthma. What is difficult to treat asthma? We use a lot, and some people confuse this with severe asthma. Difficult to treat asthma is uncontrolled asthma despite being a medium or high dose ICS-LAVA combination and despite specialist management. It is necessary to question the reality of asthma, the associated differential diagnosis potentially involved in lack of control, and it is always necessary to assess adherence to therapeutic strategies, including inhaler technique, management, asthma action plan, and so on. So when we assess difficult to treat asthma, we have to look at all these contributing factors, including inhaler technique and compliance. Gastroesophageal reflux is also a comorbid condition. If patients smoking, we need to stop smoking. If patients using beta blockers or NSAIDs, we need to switch to alternate medication. Obesity is a common confounder. It can exacerbate asthma as well. So we need to make sure that this thing is controlled by dietary plans, exercise, motivational therapies, and sometimes drugs and surgeries. Anxiety and depression is also a confounding factor, and we commonly use this HAD score in assessment of anxiety and depression in these patients when we are assessing difficult to treat asthma and give medication if required. A couple of new things that we always check when we assess these patients is inducible laryngeal obstruction, ILO, and dysfunctional breathing. So ILO patients present with voice changes, loss of voice, throat tightness, throat wheezing, and the diagnostic criteria, either we use a flow volume loop. There is an ILO questionnaire, and we also have got the gold standard, which is fiber optic laryngoscopy done in exercise. The treatment is speech therapy, psychological support, sometimes inspiratory muscle training is required. Dysfunctional breathing is, we use quite a few terms for that: periodic breathing pattern disorder. These patients, we use a scoring system known as Nijmegen score. I'll show you in a minute. And the manual assessment of respiratory motion, breath holding time. These are a few of the things that we use for assessing dysfunctional breathing. We need to rule out these conditions before we label the patient as severe asthma. So ILO is inappropriate transient reversible narrowing of larynx in response to external triggers. We used to call vocal cord dysfunction when we were trainees, and we see this pattern, variable extrathoracic obstruction on flow volume loop. This is exercise-induced fiber optic laryngoscopy, which is the gold standard for diagnosis. We ask the patient to do exercise either on a treadmill or just go for a long running outside and then come back, and we can see this reversible vocal cord dysfunction when we do the fiber optic laryngoscopy. Dysfunctional breathing is a respiratory condition characterized by irregular breathing patterns in absence of cardiorespiratory disease. Previously, we used to call it vocal cord dysfunction or periodic breathing, and this is a very important co-founder in patient with asthma. This is a questionnaire we use, Nijmegen questionnaire. If this score is more than 23 out of 64, it indicates this dysfunctional breathing. We've got more diagnostic tests like cardiopulmonary exercise testing, which is the gold standard for diagnosis of dysfunctional breathing. So, out of all the patients with asthma, 24% have high intensity treatment, 17% are difficult to treat asthma, and only 3.7% have severe asthma. So many of the patients that we see in our clinics are either difficult to treat asthma and not severe asthma. So we need to rule out all these conditions before we label the patients as severe asthma. So what is severe asthma? Asthma that remains uncontrolled despite adherence with maximum ICS LAVA, who have poor symptom control despite management of confounding or contributing factors. Patient experience heavy symptom burden, exacerbations, admissions, and medication side effects. Can lead to severe emotional and social impact. Appropriate diagnosis management is critical, as these are the patients who are the ones who land in ITU, and there are asthma-related deaths in these patients who are poorly recognized severe asthma patients. The pathophysiology includes airway inflammation, airway remodeling, and abnormal airway and lung mechanics, and role of phenotypes. We know that high Th2 inflammation is characterized by interleukins and high eosinophil levels, and low Th2 responses can be characterized by increased number of neutrophils, which we'll discuss in a couple of slides. So this is a normal airway, and you can see patient with severe asthma, lot of inflammatory cells. You can see airway remodeling happening here with the smooth muscle hypertrophy and hyperplasia and mucus in the center of the airways. Few of the important cells that involve in pathogenesis of severe asthma and asthma in general are the bronchial epithelial cells, the Th2 cells, eosinophils, we have got dendritic cells and antigen-presenting cells as well. So one of the new factors that we have found is TSLP. I'll discuss this in a little bit more detail, which is released by bronchial epithelial cells and is a new factor that is a potential target for treatment in severe asthma. Eosinophils are mediated by interleukin-5, 13, and then we have got Th2 cells that release interleukin-4 that affect the B cells, and B cells release IgE. So these are the important cells that are required in the pathogenesis of severe asthma. I'm not going into the detail of spirometry. We all know that airway obstruction with bronchodilator reversibility is hallmark of asthma. However, severe asthma patients may not have the bronchodilator reversibility that we see in patients with the normal asthma patients. FeNO is a very important biomarker that reflects underlying respiratory tract inflammation, provides an easy, non-invasive, reproducible way to detect airway inflammation in some patients with asthma. High FeNO is associated with a high eosinophilic phenotype, and this is a potential target for treatment. So FeNO has been used as diagnostic, predictive, and prognostic factor in patients with severe asthma. Diagnostic as in GINA 2020 guidelines, if the FeNO value is more than 50 parts per billion, it is diagnostic of asthma. It is also predictive of ICS response, and it can tell us about inhaled corticosteroid compliance. If a patient has a high FeNO level despite appropriate therapy, we should question the compliance to ICS as well. So we need to make sure the patient is taking the treatment regularly. It is also a prognostic value. High FeNO is associated with increased number of exacerbations, increased risk of asthma-related deaths, and low lung function and poor asthma control. We know about these factors that affect FeNO anyway. So when we assess the phenotypes of asthma, we do a lot of tests, and these are few of the tests that we do. One is IgE level, should be more than 100, but should not be in thousands, because if IgE is more than 1,000, we need to rule out APB. RAS sensitivity to common allergens, we do ENCA to rule out GPA, and eosinophils should be high in eosinophilic asthma, and sputum eosinophils are done, and FeNO should be more than 25. These are the potential sites of treatment we'll discuss in a minute. High resolution CT chest is always done in assessment of asthma to rule out air trapping. You can see air trapping very clearly in expiratory CT, and to rule out bronchiectasis, as bronchiectasis can indicate presence of APPA or airway obstruction secondary to bronchiectasis. And when we assess severity of asthma, we do these questionnaires: ACQ-7, AQLQ. We assess exacerbation frequency last 12 months, admissions in visits, IETQ admissions in the last 12 months, use of oral steroids, and maintenance steroids. Because the purpose of monoclonal antibodies is to reduce these things: frequency, exacerbation, admissions, and use of oral steroids or the dose of maintenance steroids. So when we assess holistically severe asthma patients, we assess what is the diagnosis confirmed. We rule out difficult asthma patients, and we cluster phenotypes. We know whether it's an eosinophilic phenotype, it's a neutrophilic phenotype, it's a non-atopic phenotype, and then manage the patients accordingly. And severe asthma patients, if they are eosinophilic, they're treated with mepo or rascuzumab or benralizumab, or omalizumab has gone into disfavor. I'll discuss in a minute. So severe asthma patients always discussed as in a multidisciplinary team, and it should be always be discussed as a multidisciplinary approach, because many heads are better than one head. And our members specialist nurses, physiologists, ENT specialists important to rule out difficult asthma, speech and language therapists, and pharmacists. So this is taken from the GINA guidance. You can see if eosinophilic inflammation, this is the treatment targets. If non-eosinophilic inflammation, if it is neutrophilic, we give macrolides or anti-interleukin 17. With non-atopic phenotype, treatments are limited. Bronchial thermoplasty has gone into disfavor in these patients as well. These are the potential targets. We have discussed most of them. I think it will be discussed later. I would skip these slides. So monoclonal antibodies, if IgG is positive, then omalizumab can be used. However, FDA has given a warning against risk of anaphylaxis in these patients, so it's gone into disfavor. We don't use it if we have alternate options. Interleukin 5 are used in eosinophilic inflammation or interleukin 5 receptor antibodies. If patient has concomitant eczema or nasal polyposis, we use and other potential options are you can take from the slide. So in summary, detailed evaluation required to differentiate difficult to treat from severe asthma, and role of biologics in non-thymic 2 asthma is less clear. Thank you very much.
Thank you, Dr. Kanwal. Any questions from audience?